Thank you for the opportunity for allowing us to present these data, and I'm presenting on behalf of the EPIC network. That's my disclosure. So Dolutegravir has been recommended as part of first and subsequent line ART treatment for children and adolescents living with HIV since 2021. The Odyssey randomized control trial is the largest trial in children. The Odyssey randomized control trial is the largest trial in children on DTG to date, and they've reported viral and clinical failure at, as 13% at 96 weeks and 20% at 190 weeks on those in the DTG arm. There are limited data on viral failure among children and adolescents in routine care data settings, but the few studies that have reported viral failure have the estimates have ranged from 4 to 34%, and these have been reported over varying timeframes, and the definitions of viral failure have differed in the studies. The aim of our work was to assess viral failure in children and adolescents with HIV on Dolutegravir in Europe and Thailand. We used data from the European Pregnancy and Pediatric Infections Cohort Collaboration, or EPIC. EPIC pools and standardizes data from cohorts across Europe and Thailand. And in 2023, data were pooled in children and adolescents aged under 18 on DTG. And the inclusion criteria for our analysis was children under 18 at DTG start with 2 or more viral load measurements after 24 weeks on DTG and not receiving DTG as part of a clinical trial. So these are our methods. We defined viral failure as 2 consecutive viral loads of 400 or above, or 1 viral load of 400 or above, followed by DTG discontinuation after 24 weeks on DTG. Our outcome was time to failure, and we censored patients at the earliest of discontinuation of DTG without failure, death, or last suppressed viral load. Cumulative incidence of viral failure was estimated using Kaplan-Meier methods, and Cox proportional hazard models were used to assess associated factors, and multivariate models were adjusted for age, sex, and art and viral load status only, as there were too few events of failure for a fully adjusted model. And the potential factors we examined were age, sex, art and viral load status, previous treatment failure, WHO immune stage, and region. So on to the results. Overall, 1,231 had ever been on DTG, aged less than 18. And of those, 778, which was 63%, met the inclusion criteria for this study. And 58, which was 8%, met the definition for viral failure, and then with a median time to failure of 81 weeks. So now looking at the demographic and clinical characteristics at DTG start for this group, around half were female. In terms of region, 34% were from the UK and Ireland, 3% were from Thailand, and 13% from the Ukraine, and 50% were from the rest of Europe. The median age at DTG start was 14 years, and 10% were ART naive at DTG start, and 13% were ART experienced and viremic above 200, and more than half at 56% were ART experienced and suppressed. The remaining 21% were ART experienced but with a viral load that was unknown. And the median duration on DTG was 137 weeks. So here we look at the key differences between the clinical and demographic characteristics in those that failed and those that didn't fail. So among those that failed, 72% were female compared to 51% in the group that didn't fail. In terms of ART and viral load status, in the group that failed, a larger proportion were ART naive and ART experienced and viremic, and a lower proportion were ART experienced and suppressed. Just over 1/3 of the group that failed had advanced or severe WHO immune status, compared to 11% in the group that didn't fail. And 43% in the group that failed had a history of previous treatment failure, and also a longer duration on DTG. So moving on to the cumulative incidence of viral failure, this graph shows the incidence with the 95% confidence interval shown in blue, and 4% cumulative incidence of failure was 4% by 96 weeks and 8% by 144 weeks. So this plot shows the unadjusted incidence of viral failure by sex, and the table below shows the hazard ratios for both the unadjusted and adjusted models. And you can see here that the hazard of failure was over twofold higher among females after adjusting for age and ART and viral load status. This is the same plot but by age group at DTG start, and it looks like there's higher incidence of failure in the older age group that were 12 to 18, but these were not found to be significant in the unadjusted and adjusted results. This is incidence of failure by ART and viral load status, and the incidence was higher among those that were ART experienced and viremic, which shown by the red line, which reached 24% failure by week 144, and it was lowest among those that were ART experienced and suppressed, shown by the green line, and it was estimated at 3% at the same time point. After adjusting for age and sex, the hazard of failure was 4 times higher in those that were ART experienced and viremic at DTG start compared to the reference group that were ART experienced and suppressed. So this is WHO immune stage at DTG start, and the hazard of failure was twofold higher in those with advanced or severe immune status at DTG start compared to those with none or mild immunosuppression after adjusting for age, sex, and ART and viral load status. So looking by previous treatment failure, the incidence, the hazard of failure was over twofold higher in those with previous treatment failure compared with no treatment failure. And finally, just looking by region, yes, there was evidence of a lower hazard of failure among those from Ukraine and the rest of Europe compared to the reference group of UK and Ireland. But we note that this may be driven by differing frequencies of viral load monitoring across the different regions. So to summarize our findings, the overall incidence of viral failure by nearly 4 years was low at 9%, and this is lower than the finding from the Odyssey trial of 20%, but bearing in mind that their definition of viral failure incorporated clinical failure, which we didn't include, and our population is very different, as over 50% were ART experienced and suppressed at DTG start. In our cohort, incidence of viral failure was markedly higher among those that were ART experienced and viremic at DTG start, and reaching 24% by week 144, which warrants further monitoring. After adjusting for age, sex, and ART and viral load status at DTG start, being female, ART experienced and viremic, having advanced severe WHO immune stage, previous treatment failure, or living in the UK or Ireland were associated with a higher hazard of viral failure. Our analysis was limited due to the low number of failure events, and we also had limited data in young children aged under 6. Data and outcomes after failure on DTG is urgently needed, and our work highlights the need for universal access to potent subsequent treatments and identifying optimal management strategies. And just to flag, the posters from our group, we have a poster on the broader safety and effectiveness of DTG and a poster on modelling growth as well. And finally, I'd just like to thank all of the patients that participate in our cohorts and all of our collaborators.